Good evening again, our dear friends and viewers from Egypt and all over the world. Tonight, Thursday's clinical discussions at CEC. We are live on the CEC channel on YouTube. We will be discussing tonight a very interesting topic, venous thromboembolism, and one of its serious devastating conditions and complications, the chronic thromboembolic pulmonary hypertension condition. I'm very glad and honored to have with me tonight on board two very elegant speakers, Dr. Karim Mahmoud, the lecturer of cardiology at Cairo University and one of the co-founders and eminent board members of the CEC. Dr. Karim will go smoothly with us through 5 different clinical scenarios in pulmonary embolism, which need to grab our special attention so we can put a guideline-directed plan on how to manage each one of those conditions. This will be followed by our eminent speaker tonight, Professor Ahmed Hassan, lecturer of cardiology at Cairo University and member of pulmonary arterial hypertension team at Aswan Heart Center. Dr. Ahmed Hassan will give us a talk about the chronic thromboembolic pulmonary hypertension, CTEPH, as a complication to the recurrent and repeated pulmonary embolism. So after this short introduction, I know we are all interested to hear what's next, so I will pass the mic to my dear friend, Dr. Karim Mahmoud. So Karim, the mic is yours.
Thank you, Mohammed. I'm glad to have today Ahmed Hassan with us on this very hot topic, which is pulmonary embolism and chronic thromboembolic pulmonary hypertension. So I'm sharing my slide now. Are you seeing my slides?
Yes, your slides are clear, but your voice is a bit glitching, so maybe you need to shut down your video so the internet is focusing on the PowerPoint presentation.
Okay. So you hear me well right now?
Much better than previously, yes.
Okay. So I'm going through different scenarios in pulmonary embolism. So every now and then we encounter an echocardiography like this in a patient with chest pain and or shortness of breath, mainly hemodynamic instability and hypotension. This points to the devastating medical emergency, which is pulmonary embolism. Here we can appreciate the markedly dilated right ventricle with pressure and pressure overload on the left ventricular septum. So this needs an immediate action and rapid intervention to treat and manage this medical emergency. So let's start with this scenario of a 70-year-old lady. She had a history of previous DVT later. And she is known to have hypertension with other history. She presented with a right lower pain of a 4 hours for pain duration and acute and shortness of breath. So, based on this clinical scenario, this makes us think about.
Karim, interrupt you for a minute. I don't know, your internet connection is glitching in the voice so much. Is there any option that you can join from a hotspot from your phone? So Dr. Karim is just changing his internet access, and he will be with us in the next couple of minutes. If he was a little bit late, more than 2 or 3 minutes, maybe Dr. Ahmed Hassan can start while Karim solves this issue. So I think Dr. Karim is back now.
So sorry for the network problem. Can you hear me right now?
Is much, much better.
Yes.
I would like you to start from the beginning of the case presentation,
Yeah,
please.
yeah, yeah. So this is a 70-year-old female lady with a history of previous DVT several years ago. She is known to have hypertension and presented with right lower limb pain over 4 days duration and acute shortness of breath. Of course, when we encounter a patient like that, we suspect pulmonary embolism based on the clinical judgment. However, the guidelines recommend a more validated way to evaluate and to suspect pulmonary embolism based on many prediction rules. The most famous of them is the revised Geneva Clinical Prediction Rule. So here we depend on several clinical factors such as previous pulmonary embolism or DVT, the tachycardia, surgery or fracture within the past month, hemoptysis, active cancer, unilateral lower limb pain, pain on lower limb, deep venous palpation and unilateral edema, or elderly with age more than 65 years. So let's revise our patient here. She had a history of previous pulmonary embolism. She has a unilateral lower limb pain, and she is elderly, and her age is 70 years. So here to complete our clinical picture, we should know data about her vital signs. And her heart rate was 110 beats per minute, and her blood pressure was 80 over 60 millimeter mercury. So if we calculate her score, it would be about 12, which indicate here a high probability of a pulmonary embolism. So the next question that comes to our mind, is this patient unstable? And to answer this question, let's revise the definition of hemodynamic instability in the guidelines. It's defined based on one of the following: either a cardiac arrest with a need for cardiopulmonary resuscitation, or the presence of obstructive shock defined by the systolic blood pressure less than 90 millimeter mercury, or vasopressors are required to achieve a blood pressure more than 90 millimeter mercury in the presence of a hypoperfusion, or the presence of persistent hypotension with the systolic blood pressure less than 90 millimeter mercury, or a drop more than 40 millimeter mercury lasting longer than 15 minutes. So the instability is defined by the cardiac arrest, the state of shock, and the persistent hypotension. If we think about our patient, she has a history of hypertension, and her blood pressure now is 80 over 60. So I think she had a hemodynamic instability in the presence of a persistent hypotension, and maybe she is going into a shock state. So our patient is a pulmonary embolism or high likelihood of pulmonary embolism with a hemodynamic instability. What we need, the first step is to do a bedside transthoracic echocardiography, which can reveal RV dysfunction as the initial echo was shown in the first slide. I believe now that echocardiography machine are present in most of our CCU and emergency departments, so it's essential to diagnose a pulmonary embolism to do a bedside transthoracic echocardiography at the presentation. So if the patient have RV dysfunction, the pulmonary embolism will be likely. And if not, I think in the presence of hemodynamic instability, we should search for other cause because the pulmonary embolism with hemodynamic instability is unlikely to occur without RV dysfunction. The next step is to know the protocol of our center, of your center. If the CT pulmonary angiography could be done safely and it's feasible, you can perform a CT pulmonary angiography to confirm your diagnosis. Otherwise, if not, and you have a high probability of PE with RV dysfunction and echo, you should proceed to management of these patients. And so, as we said, the guidelines recommend the bedside echocardiography as a class 1 and to start unfractionated heparin immediately without delay in these patients with a high risk PE. And for hemodynamic support, we can do several things. We can optimize the volume with cautious volume with saline or ringer, but avoid overloading with the volume because this can cause a more RV dysfunction. You can give a vasopressor such as norepinephrine if the patient is in a profound shock, or dobutamine if the patient have a borderline blood pressure, or if it is feasible to use the veno-arterial ECMO. So to continue the management of our patients, it's essential in a patient like this to give a systemic thrombolysis if the thrombolysis is not contraindicated. Otherwise, if the thrombolysis is contraindicated, we can do a reperfusion with either surgical pulmonary embolectomy or percutaneous catheter treatment. And we have a different mechanism for doing the catheter directed reperfusion of pulmonary emboli with either a mechanical defragmentation using a special catheter or ultrasound fragmentation, and we can use also a local thrombolytic therapy for pulmonary or massive pulmonary emboli. So to conclude this part, in the patient with PE with a hemodynamic instability, we need a rapid action with rapid collection of clinical data and define instability, the bedside transthoracic echocardiography and the CT pulmonary angiography if feasible. Hemodynamic support is recommended, and systemic thrombolysis, and if contraindicated, we can do surgery or percutaneous directed catheter treatment. So this is the first part regarding the patient with PE and hemodynamic instability.
So thanks a lot, Karim, for this very comprehensive approach. You made it very easy. First of all, we have a score for diagnosis of the pulmonary embolism. And second of all, we have the clinical data of the patient combined with the echocardiographic features, where we classify the patient into a hemodynamically stable or a hemodynamically unstable. And then we have a flow chart that will show us if the patient is hemodynamically unstable and it's not contraindicated to give thrombolysis, then we will go through thrombolysis. And we need to move rapidly because pulmonary embolism is one of the major causes of mortality actually, and sometimes we skip the diagnosis because we're just not thinking about it. So thank you very much for this elegant first part, focusing on the very important points, and I think we can move to the second.
Thank you, Mohammed, for rehearsing this first part. And moving forward to the second scenario with this 30-year-old female lady, she has no history of previous venous thromboembolism. However, she is taking oral contraceptive pills, and she presented with acute shortness of breath. So you suspect here a pulmonary embolism based on either a clinical suspicion or a prediction rule. However, the prediction rule and the revised Geneva criteria, as we mentioned before, is more validated, and you can deal with the patient of pulmonary embolism with number, which helps you to know in which category you would risk stratify your patient. So again, this is a revised Geneva prediction rule. Our patient have a vital sign with a heart rate of 120 beat per minute. So it would give her a score of 5. Her blood pressure is 110 over 70. She is tachypnic with respiratory rate of 32 per minute. And there is some hypoxia with saturation is 89%. So based on the revised Geneva prediction rule, we would give the patient a score of 5, which classify here as an intermediate probability of pulmonary embolism. Of course, this should be done together with the differential diagnosis and the exclusion of other causes of acute shortness of breath. So this patient has no hemodynamic instability, and we have a different algorithm for patients with pulmonary embolism without hemodynamic instability. First of all, we should assess the clinical probability as we did before, based on the clinical judgment or prediction rule. If the patient have a high clinical probability, we should go immediately for CT pulmonary angiography for pulmonary embolism diagnosis. If not, if the patient has a low or intermediate clinical probability, so the most appropriate action will be D-dimer. And if D-dimer negative, in most of cases, we can exclude a pulmonary embolism as working diagnosis. And if it is positive, so we should do a CT pulmonary angiography for a confirmation of the diagnosis. So the use of validated criteria, as we mentioned, is recommended and the class 1 recommendation in the guidelines. And we should initiate anticoagulation in a patient like this immediately while we continuing our diagnostic procedure. And regarding the D-dimer, we should use the highly sensitive assay rather than the intermediate or low sensitive assay. And we should do that with knowing that D-dimer values increased with age. So if we have a patient more than 50 years, we should have a different cutoff value than the patient less than 50 years. For example, our patient, we have a patient with PE, and she is a 60-year-old. So the cutoff value here should be 60 times 10, which is 600, rather than the 500 microgram per liter in the younger patient. In the patient, as we mentioned, with a high clinical probability of pulmonary embolism, D-dimer is not recommended. So moving forward to the gold standard investigation in diagnosis of pulmonary embolism, which is the CT pulmonary angiography. If the CT pulmonary angiography is normal, we can exclude pulmonary embolism. If the CT and this in the patient with either low, intermediate, or high clinical probability. However, if the CT pulmonary angiography shows a segmental or more proximal filling defect, we can accept the diagnosis of pulmonary embolism. Some centers use the VQ scintigraphy. However, most of our centers don't use the VQ scan for routine diagnosis of pulmonary embolism. And we can use also in some cases, especially in the pregnancy, the lower limb compression ultrasound to detect the proximal DVT, which can make us accept the diagnosis of the venous thromboembolism. It's a very easy. It's done by a compression at the groin, as we can appreciate here. Without compression, we can see the common femoral artery and the common femoral vein. On compression, the common femoral vein normally become totally compressible. However, in the patient with the DVT, on the compression, the femoral vein won't be compressible, and we can detect this hypoechoic echo thrombus in the femoral vein, as we can appreciate in this duplex images. So D-dimer was done and it was elevated, and CT pulmonary angiography was done and revealed a filling defect in the right main pulmonary artery, which confirmed the diagnosis of pulmonary embolism. So what is the next step? The next step would be the risk stratification of these patients. And there is a multiple parameter for risk stratification. First of them is a one of clinical judgment, which is pulmonary embolism severity index, which consists of many clinical parameters, as we can appreciate: age, male sex, cancer, chronic heart failure, chronic pulmonary disease, tachycardia, hypotension, tachypnea, hypothermia, altered mental state, and hypoxia. So if we see our patient has she's 35 years, she is tachycardic and tachypnic and has hypoxia. So it would be classified as a class 3 according to the original score, and more than 1 in the simplified risk score. So the red one we discussed in the previous patient, which is the patient with a high clinical probability. And if the patient is without hemodynamic instability and have a high pulmonary index, pulmonary embolism severity index with RV dysfunction on echo and elevated cardiac troponin, it would be risk stratified as intermediate high. If high pulmonary embolism severity index with RV dysfunction especially, it would be intermediate low, and absence of the all above factors would classify the patient as a low risk. So to conclude and to have an overview on the management of pulmonary embolism, we should anticoagulate immediately and we should look for the hemodynamic instability. If the patient is hemodynamically unstable, he would be classified as a high risk and should receive the reperfusion therapy. If not, we should check for the pulmonary embolism severity index and RV dysfunction on echo or the CT. If one or two are present, we should perform a troponin test, and if positive, we would consider our patient as an intermediate high, and if they are absent, we should consider this patient as a low risk. So what about the management? We should, as we agreed, initiate the anticoagulation immediately, and the parenteral anticoagulation of choice would be the low molecular weight heparin or fondaparinux, and NOACs are preferred now over the VKA, except in some cases such as the pregnancy, lactation, antiphospholipid syndrome, and severe renal impairment. And we would we would not give a routine thrombolytic therapy for the patient with intermediate and low risk PE. We should only give these drugs if the patient has hemodynamic deterioration, and if there is a contraindication for thrombolytic therapy, we can perform surgical embolectomy or percutaneous catheter direct treatment. And the IVC filter is reserved only for the patient with absolute contraindication to anticoagulation, or if there is a recurrence despite anticoagulation. So to conclude this part, if the patient have PAE without hemodynamic instability, again, we should do a clinical assessment, and it should be done on based on the protection rules such as revised Geneva criteria. If the patient have a high probability, the method of the choice will be CT pulmonary angiography. And if the patient has a low intermediate probability, high sensitive D dimer should be performed first, and if positive, the CT pulmonary angiography should be done. Then the risk stratification based on pulmonary index, severity index, RV imaging, and troponin. And anticoagulation should be started immediately, either a parenteral anticoagulation with a preference of low molecular weight heparin and fondaparinux, or oral such as NOACs. And we should know the contraindication of NOACs to be used in the pulmonary embolism. And it is not routine to use a thrombolytic therapy and IVC filter. These parameters should be used in a special situation, as we mentioned earlier. So here we finished this part with the patient with pulmonary embolism without hemodynamic instability.
Thank you
So
so much, Kareem, for this elegant presentation. And actually, this slide wraps up everything for the patients that is not presenting with a hemodynamic instability. We clinically assess the patient, which is helped by the prediction rule of the Geneva. And then if the patient, we need to exclude pulmonary embolism, he has a low risk, we do the test of exclusion, which is D-dimer. If the patient has a high probability, we do the test of confirmation, which is the CT pulmonary angiography. The echocardiography and the troponin will help us to stratify the patient from the low risk profile to the higher risk profile, where we will give him the thrombolysis if indication, and in all cases, anticoagulation will be taken. We'll just take care that the NOACs do not work in the antiphospholipid antibody syndrome, and we have no data about giving NOACs in the pregnant babies. Thank you so much, Kareem, also for wrapping up this part for us. And I'm very interested to see the remaining miscellaneous situations.
So thank you again, Muhammad, for this wrap up. And after we treat the patient or the acute after the acute treatment of pulmonary embolism patient with or without hemodynamic instability, we should know an important question, which is what is the duration of anticoagulation? So for all patients of pulmonary embolism, therapeutic anticoagulation should be done for at least 3 months. And we can discontinue this anticoagulation in a special subset of patients, which is the patient with a first pulmonary embolism or venous thromboembolism, secondary to a major transient or reversible risk factor. So we can discontinue anticoagulation in this group of patients. Let's revise this group of patients. Sorry. So, what are the major transient or reversible factors? These factors are associated with a low risk of recurrence of the venous thromboembolism, such as surgery with general anesthesia more than 30 minutes, or if the patient is bedridden for more than 3 days due to acute illness or acute exacerbation of chronic illness, or trauma with fracture. These are a major risk factors for pulmonary embolism, but associated with a low incidence of recurrence if this is a first attack, and we can discontinue according to guidelines the anticoagulation after 3 months. Okay, what about the patients in whom extension of anticoagulation would be beyond 3 months? This is a class 1 indication in the patient with recurrent venous thromboembolism, especially if not related to the major transient or reversible factor, and in the patient with antiphospholipid antibody syndrome. This would be a long-term anticoagulation in this type of patient. So, and the long-term anticoagulation should be done if the patient have a first episode of pulmonary embolism with no identifiable risk factor or a persistent risk factor other than antiphospholipid antibody syndrome, or if the patient have a minor transient or reversible risk factor. This is the reversible or the other risk factor that were mentioned in the guidelines for the transient or reversible risk factors that are associated with intermediate long-term recurrence, such as the minor surgery, the hospitalization for less than 3 days, estrogen therapy, as in our patient, pregnancy, and leg injury without fracture or the long flight. and the non-malignant persistent factor such as inflammatory bowel disease or active immune disease, and or maybe no identifiable risk factor. So if our patient have a first episode with these factors, long-term anticoagulation should be recommended for this patient, but it is a class 2, class 2A recommendation. What about NWAC? NWAC dose can be used as an extended anticoagulation, especially the apixaban dose 2.5 milligram or rivaroxaban 10 milligram after 6 months of therapeutic anticoagulation. And we should follow the patient with anticoagulation regarding the kidney and liver function. So again, to conclude this short part, the long-term the anticoagulation should be given at least 3 months following pulmonary embolism, and we can stop after 3 months if it is a first episode with major transient or reversible risk factor. We must continue beyond 3 months if the pulmonary embolism were recurrent or associated with antiphospholipid antibody syndrome, and we should continue as a class 2A if it is a first episode with no identifiable risk factor or persistent risk factor other than antiphospholipid or a minor transient risk factor as we mentioned earlier. So this is the third part of our presentation regarding the duration of anticoagulation. So Muhammad, what do you
Thank
think?
you. Thank you so much, Karim. So in the previous version of the guidelines, it was 6 months. The number has been replaced now to 3 months, and we take the situation assessment. If we are already on a low risk for recurrence, we should stop after 3 months. If we have a higher risk of recurrence, we must continue beyond 3 months and take care that antiphospholipid antibody syndrome is one of the worst situations where you most probably will continue beyond 3 months up to maybe for life, because the situation also involves recurrent abortion, situations during pregnancy, and so on. You may continue beyond 3 months after assessing the bleeding risk of your patient, especially if it is the first episode and if it is the no persistent or minor transient. So actually, I do agree with this version of the guidelines because it gives us a more tailored approach according to every situation and according to every patient. Thanks a lot, Karim, for summarizing this part. And maybe we have another two miscellaneous situations you need to discuss with us.
And thank you, Muhammad, for mentioning the antiphospholipid antibody syndrome. And we should stress that VKA here is the anticoagulation of choice rather than wax. And rivaroxaban was actually tried in the antiphospholipid antibody syndrome and was associated with increased thrombotic events. So the VKA is the drug of choice in the BA associated with antiphospholipid antibody syndrome. So moving to another scenario with a 25-year-old pregnant lady, 11 weeks gestation. She was bedridden due to a threatened abortion in the last few weeks, and she complains of left lower limb pain that is followed by progressive shortness of breath, tachycardic on a rate of 100 beats per minute, and the blood pressure 110 over 80 millimeter mercury. So a pregnant lady with a suspicion of pulmonary embolism, difficult clinical scenario. Why is that? Because if we suspect pulmonary embolism and we don't have a hemodynamic instability, we would treat it as previously and do a D-dimer test. However, the D-dimer test can be falsely elevated in pregnant ladies, and with moving forward in pregnancy, the values and the cutoff values of D-dimer can increase. However, if we suspect the pulmonary embolism during pregnancy, as we mentioned earlier, we should anticoagulate with low molecular weight heparin. So, and then we should know what are the estimated amount of radiation in our tools that we would use in the diagnosis of pulmonary embolism in the pregnant lady. And it's now agreed that all the imaging modalities are associated with a low radiation exposure for both mother and fetus, and they should be used when needed in the diagnosis of pulmonary embolism. So here, to continue the algorithm of patient with the PEU and the pregnancy, chest X-ray can be done, and here the ultrasound, the duplex ultrasound is very beneficial because if we have a proximal DVT, we can accept the diagnosis of pulmonary embolism, and we can continue without further imaging, which have a burden of fear on the mother and her baby. However, if we didn't detect a proximal DVT by duplex ultrasound, we can continue with either a CT pulmonary angiography or perfusion lung scan if the X-ray is normal. And we should take into consideration that the radiation exposure from the perfusion lung scan is lower than the CT pulmonary angiography. However, again, the CT pulmonary angiography can be done for the pregnant mother if needed. And according to this investigation, either the pulmonary embolism would be ruled out or would be confirmed. So the anticoagulation would continue, and we continue our risk assessment according to the slide mentioned earlier. So the treatment would constitute of low molecular weight heparin, a fixed dose of low molecular weight heparin according to the body weight in early pregnancy. And if the patient have a high risk pulmonary embolism and need thrombolysis, we can perform thrombolysis or systemic thrombolysis or surgical embolectomy, keeping in consideration the adverse event of this procedure in a pregnant lady. Some recommendation not to do in pregnant lady, which is injection of epidural needle, low molecular weight heparin within 4 hours of removal of epidural catheter, and NWAC. NWAC again should not be used during pregnancy or lactation. And the guidelines mentioned a very special situation of pulmonary embolism, which is amniotic fluid embolism. Here, the source of the embolus wouldn't be a thrombus, but rather than amniotic fluid. And it is a very critical situation and associated with a worse prognosis because it would be associated with unexplained cardiac arrest, sustained hypotension, or respiratory deterioration, and maybe DIC. So we should consider also this condition, especially in the patient, if the patient is delivering or in the postpartum period. So here I finished the fourth part of which is the pregnant lady with a pulmonary embolism, and this is the last part with which is a cancer patient and the pulmonary embolism, which has some few recommendations, but it is very important. It is regarding to use the low molecular weight heparin in extended duration during the first months following the pulmonary embolism. And we can use also some NWACs that studied in the patient with cancer, such as edoxaban or rivaroxaban, except in the patient with gastrointestinal cancer. And for how long? It is recommended to use the anticoagulation beyond the first 6 months, and this should be continued maybe until the cancer is cured. And if we incidentally found pulmonary embolism during the imaging or evaluation, we should treat them in the patient with cancer the same manner as the symptomatic pulmonary embolism. So I finished here, I stopped here with the pulmonary embolism, and I would give the stage to my dear friend Ahmed to continue the challenging part of the CT pulmonary hypertension. But I would be happy to hear the comments from Muhammad Zahran and from Ahmed Hassan as well.
Thank you so much, Karim, for wrapping up this very important part, which is actually, let's say, an introduction to what Dr. Ahmed Hassan will be discussing with us. So, Dr. Ahmed, you have the mic now. First of all, maybe you can give us some comments and insights about Karim's part, and then you can directly start sharing your slides.
So, Ahmed,
Can you hear us?
Yes, I'm with you now. Okay.
okay. So, do you have any comments regarding the previous the recommendation of the guidelines? Can you highlight any of these recommendation and that is very important in our clinical practice?
Thank you, Karim, for your elegant, concise lecture. Actually, I have a question just to discuss some scenarios that we faced in our real life about patients that are already in therapeutic doses of anticoagulation and presenting with acute pulmonary embolism. What is different in management in acute and on the long-term management on those group of patients? How do you think that if the patients already on warfarin, what will change our decision? يعني إيه اللي يتغير في our decision during acute and also in the long-term follow-up?
Okay, thank you, Ahmed, for this nice question and this very tough clinical scenario actually. So we can have a patient with a venous thromboembolism while on oral anticoagulation, either warfarin or NOACs. So I think this patient would have a risk factor for recurrence. So first, I believe we should search for this risk factor of recurrence, of high recurrence of venous thromboembolism, despite being on anticoagulation. The acute management, we would shift to a parenteral anticoagulation, and if this patient actually on high risk side, we can give systemic thrombolysis, given taken in consideration the high risk of bleeding if this patient already on anticoagulant. However, the long-term anticoagulation, I believe shifting to other aspects would be good. So if this patient is, as we mentioned, has an antiphospholipid antibody syndrome, shifting from NOAC to VKA would be good, and putting the patient on the high side of INR, maybe 3 and more. And if the patient has a problem regarding the anticoagulation with warfarin, and it cannot control his INR, so the NOACs can be good for this type of patient. However, as we also mentioned, if the patient has recurrence despite anticoagulation, here the IVC filter would be recommended in this type of patient to decrease the risk of recurrence, taken in consideration not to stop anticoagulation in this patient, and may we enforce and augment the protocol of anticoagulation in this type of patient. So, what do you think? Can you add any other thing regarding the management?
No, thank you, Karim. You already covered all the aspect. I think diagnosis and management of this group of patients is a really challenge. Sometimes they have already pulmonary hypertension from a previous pulmonary embolism, and they are presenting with some fake presentation. And sometimes the diagnosis is really difficult to diagnose a new pulmonary embolism rather than just a decompensation of a previous thromboembolic, chronic thromboembolic disease.
Yes,
and also management of anticoagulation is really challenging. IVC filters is is a good way to prevent big or large pulmonary emboli. However, usually it does not prevent small recurrent showers, and might increase the risk of lower limb DVT, as you know. Most of the studies that used retrievable IVC filter, they did not retrieve the IVC filter, so they used it as permanent filter, in fact, rather than retrievable filters.
So actually, you mentioned a very important point. I think you would mention in your presentation, which is a patient with pulmonary hypertension and has a suspicion of a new pulmonary embolism. The guidelines and the echocardiographer all know a rule of 60-60, which is if the patients have a pulmonary artery systolic pressure more than 60 millimeter mercury, this would suggest more a chronic thromboembolic pulmonary hypertension rather than a new embolic event. However, the association can happen, especially in the patient with a chronic thromboembolic pulmonary hypertension, as I believe you would give us a very practical way to manage this type of patient. So Mohammed and Haitham, if we don't have any further question, so Ahmed can start his presentation. What do you think?
Yes, please, Dr. Ahmed may start his presentation. Welcome, Dr. Haytham. If you have any comments on the previous slides, also we'd be glad to hear your insights.
Thank you, dear Mohammed, and thank you, Karim and Ahmed. You've covered all the aspects of the presentation elegantly and very well. The question Ahmed is proposing is very tough, as Karim said, and I think the gold standard or the gold weapon here is the low molecular weight heparin used until we discover what went wrong with the patient under anticoagulation and with a new event of thromboembolism. And then I think that the decision of filter, as Karim mentioned, should be encouraged early to protect these patients. I don't think there are further questions that we have, and we are welcoming our dear friend Dr. Ahmed to proceed with his presentation.
Last comment. Thank you, Haitham, for the notes of low molecular weight heparin. Actually, this is mentioned in the patient with cancer and can be applied in the patient with a failure of oral anticoagulant, either NOACs or PKA. So it's another option is to use the long-term parenteral anticoagulation with low molecular weight heparin. So Ahmed, go on, please.
It's my honor today to be invited with my colleague to this series of webinars. I'm going today to talk about chronic thromboembolic pulmonary hypertension. In fact, I will review first the diagnosis of CTEPH, and then I will present a real case scenario. Just to revise together what is the diagnosis of chronic thromboembolic pulmonary hypertension. As we know, chronic thromboembolic pulmonary hypertension is a type of pre-capillary pulmonary hypertension, which is mean pulmonary pressure 25 millimeter mercury or more, measured by invasive right heart cath, with pulmonary capillary wedge pressure of less than or 15 millimeter mercury, with pulmonary vascular resistance exceeding or equal to 3 Watt units. However, as we know that they are trying to change the value of mean pulmonary pressure to diagnose pulmonary hypertension to 20. This is in combination with the presence of chronic organized flow-limiting thrombi or emboli in the elastic pulmonary artery after at least 3 months of effective anticoagulation. The classification is a group 4 in the all the types of classification of pulmonary hypertension, and after update, last update, it's the same group 4. However, with some details added to the subtypes. We have 4 subtypes of chronic thromboembolic pulmonary hypertension. The most commonly seen type is chronic thromboembolic due to pulmonary emboli or thrombus in situ. However, we might see patients with arthritis angiosarcoma, or other congenital pulmonary disease. The most common risk factor is thrombophilia. About 20% of patients carry antiphospholipid antibodies or lupus anticoagulant or both. Any chronic inflammation might be a risk factor for for CTEPH. History of malignancy, splenectomy. Some studies show that group O might have a higher risk. It's very important to know that not all patients with chronic thromboembolic pulmonary hypertension has a history of thromboembolism or DVT. About 30% of patients has no history of venous thromboembolism at all. So is it common to have CTEPH after pulmonary embolism? And shall we screen any patient who had a previous pulmonary embolism for CTEPH? Actually, we can see this graph that shows that about 96% of cases, there is a resolution without hemodynamic compromise. But this resolution is is affecting only hemodynamics. However, a lot of patients may sustain perfusion abnormalities for a long time. And as we see here in this all the studies that showed at 2 years, only 3.8% of patients developed CTEPH after pulmonary embolism. However, from several studies, those patients who had pulmonary embolism might have persistence of perfusion defect up to 12 years. So screening for CTEPH is in asymptomatic survival is not recommended according to ACC guidelines. We have another entity which we call it chronic thromboembolic disease. This patient have a mismatch with no pulmonary hypertension. Patient who had already pulmonary embolism and the no hemodynamic consequences on the long term. However, if we did VQ scan after a few years, we can find some ventilation perfusion mismatch without any hemodynamic significance. This does not mean that this patient has CTEPH and he has they are different entity, and actually the data on CTED is very limited. They usually had a previous pulmonary embolism, and they develop symptoms of that are similar to pulmonary hypertension, like shortness of breath. However, usually the right ventricle is normal. RV systolic function is normal. They have diastolic abnormality of the right ventricle. They might have exercise-induced pulmonary hypertension in the right heart case, and some abnormality in cardiopulmonary exercise testing. Usually treatment will be anticoagulation for life and some symptomatic treatment, and no obvious studies for this group of patients. If we looked at the pathogenesis of chronic thromboembolic pulmonary hypertension, we find that CTEPH is a dual vascular disease that affects the major vessels by obliteration and the peripheral pulmonary disease vessels by increased flow. The non-occluded area showed increased flow for a long time with increasing shear stress that end into a similar picture like idiopathic type, and some autopsy study showed plexiform lesions in patients with CTEPH in the non-occluded segment. As we can see here, the severe concentric intimal hyperplasia in non-occluded segment in patients with chronic thromboembolic pulmonary hypertension. And this is the classification from San Diego that classify the CTEPH according to the place or proximity of thrombus in the pulmonary vasculature. Type 1 is the most favorable type for the surgeon, which is a major blood clot in the major pulmonary vessels. Type 2 is usually we find the thrombi in the lobar branches. Type 3 is a very distal disease, and as we can appreciate here, type 2, the lobar type and the very distal disease almost account for 75% of cases. Type 4, there is no evidence of thromboembolic material at all, and usually we find only intimal thickening. The diagnosis is sometimes difficult. We need high index of suspicion. Sometimes we have no history of venous thromboembolism at all. Common diagnostic errors like chronic obstructive pulmonary disease, asthma. Signs of heart failure is usually appear later, the time between pulmonary embolism and symptom beginning might extend to years. It is called honeymoon period. Because the right ventricle can start at that period of adaptation for a long time, then start the maladaptive response after a few years. And as we can already know the algorithm for diagnosis of pulmonary hypertension, we should first exclude left heart disease and chest disease, and then we should exclude chronic thromboembolic pulmonary hypertension. So it's an early step in the algorithmic diagnostic of algorithm of pulmonary hypertension. And if the patient has high probability by VQ scan, it's better to refer this patient to an expert center. However, sometimes we don't need to go through this all this algorithm. This patient, actually, I saw this patient a week before. As we can appreciate here, he has a huge thrombus in both pulmonary branches and dilated pulmonary artery, which indicate a long-standing disease. This patient had recurrent pulmonary embolism over a 5-year duration. Imaging in CTEPH, we have VQ scan, CT pulmonary angio, and invasive pulmonary angiography. Ventilation perfusion scan is the gold standard way to screen for CTEPH, with a sensitivity and specificity approaching 100%. There's some caveats, which in a very rare occasion, because patients with pulmonary veno-occlusive disease might show unmatched non-segmental defect in perfusion. CT pulmonary angiography is mainly for surgical accessibility. However, the old data showed that the sensitivity and specificity to diagnose chronic disease is low. But the new data with the new techniques and new machines showed that CT pulmonary angiography with a good machine and good operator had almost 96% sensitivity and 95% specificity to diagnose chronic thromboembolic pulmonary hypertension. We can find stenosis, webs, we can find total occlusion, we can find calcifications in the CT. Surgical accessibility is extremely important because proximal disease is suitable more for endarterectomy rather than very distal disease. Invasive or traditional pulmonary angiography is the old way to diagnose and to assess the operability or the proximity of the disease. The old data showed can report mortality extremely high في بعض reports up to 7%. However, in real practice دلوقتي mortality is very low. We can find webs or bands, we can find intimal irregularities, you can find total occlusion, complete obstruction and main lobar or segmental branches. It's not a routine. However, many surgeons prefer to do invasive pulmonary angiography before surgery. And we can see here, this patient had a very diffuse disease in the right upper branch, and the right lower lobar branch is almost gone. So let's go to a real life. She is a 32-year-old female complaining of short breaths and presyncope for 1 year prior to presentation, with history of iliofemoral DVT 2 years ago. She has no history of abortion. She had history of oral contraceptive use. In examination, she had right heart failure signs with low saturation, and her ECG showed incomplete right bundle with RV strain. And as we can appreciate here, the right ventricle is dilated and compressing the left ventricle. We see D-shaped septum in both systole and diastole, and we see also severe pericardial effusion. In the apical four chamber view, we can see the dilated impaired right ventricle with moderate to severe tricuspid incompetence. The pulmonary output pressure were exceeding 100. Here, ventilation perfusion scan show high probability for bilateral thromboembolic disease.
It's 10 o'clock.
And her CT showed bilateral proximal disease. This is the MRI that showed severe pericardial effusion, extremely dilated right ventricle with RV ejection fraction of 25%. In invasive right hemodynamics, her right atrial pressure was very high with 30 millimeter mercury. Mean barometric pressure was almost 60 millimeter mercury. She has LV endoscopic pressure of 6, which means capillary pulmonary hypertension. Pulmonary vascular resistance was 21 Wood units with cardiac index 1.2. It's very low cardiac index. We did the pulmonary angiogram that we just have seen. However, on the right side, we can see totally occluded lingular or totally occluded left lower lobar branch. This patient had only upper lobar branch on the left side. So what is the treatment option? We have surgery, pulmonary endarterectomy, we have pulmonary balloon angioplasty, we have some drugs, anticoagulation, and IFC filter. Pulmonary endarterectomy is a treatment of choice of most of the cases of CTEPH, especially in the main pulmonary artery, extending sometimes to subsegmental arteries. Pulmonary angioplasty can be also utilized for lobar segmental or subsegmental. We will discuss this later. For patients with microvascular disease, medical therapy is usually the drug of the treatment modality of choice. So this patient had to go for first operability, to assess operability, then for surgery. Operability is extremely important to assess symptoms, hemodynamics, comorbidities, and also the surgical experience. This surgery is usually a very high risk surgery, need a very extensive post-operative ICU care. Another example that we showed here, as we can see here, patient with totally occluded LPA, and we can see the large specimen revealed almost the same anatomy of the LPA branch. So what is the outcome after pulmonary arterectomy? The peri-procedural mortality is ranging from 2 to 5%, and some centers like San Diego, it's approaching 1 to 2% now. Survivor at 10 years is 72, which is very good. And recently, the pulmonary endarterectomy for distal chronic thromboembolic pulmonary hypertension showed almost similar results for the patient with proximal disease in expert centers. However, we might face this problem, which is a persistent pulmonary hypertension after surgery. Up to 1/3 of the patient might have persistent symptoms, and this account for the most post-operative mortality and morbidity. So this بيجي rule of pulmonary angioplasty, balloon pulmonary angioplasty. We usually use balloon pulmonary angioplasty for persistent pulmonary hypertension after surgery, or inoperable due to multiple comorbidities, or distal disease, which account for almost 30% of patients. However, it is not risk-free. We need several sessions, up to 5 sessions in some patients. Mortality per procedure or per session is 0.5%. We might face reperfusion injury, reperfusion pulmonary edema, hemoptysis. However, with the new studies and increasing training and increasing experience, mortality and complication rate is declining all over the world. Regarding medical therapy, which is usually suitable for patients who have persistent pulmonary hypertension after surgery, or patient with inoperable disease. Riociguat is a class 1 indication, which is a guanylate cyclase stimulator. We also have recent data on macitentan on MERIT-1 studies that showed improved symptoms and functional capacity. Riociguat is the only target BH medication indicated for CTEPH. This data come from CHEST-1 and CHEST-2 trials. So back to our patient that we already presented. We did a pulmonary endarterectomy, bilateral, under total circulatory arrest and hypothermia. She had 10 days in the ICU, 5 days on mechanical ventilation. So it's a very tough post-operative course. And you can see here echo, the pre-operative echo and echo at 3 months. We can see the difference. The left side become less compressed. Pericardial effusion, we have already some residual pericardial effusion. The right side becomes smaller. And we can see the difference in right ventricle. Right ventricle showed reverse remodeling. The tricuspid regurg almost become trivial. MRI 3 months later showed increased RV ejection fraction to 48%. Her right atrial pressure at 3 months follow-up was 15. Her pulmonary atrial pressure decreased to 30. Her cardiac index increased from 1.2 to 2.3. Pulmonary vascular resistance decreased from 21 to 5. And this pulmonary angiography after, we can compare it to the preoperative. So the patient would discharge on sildenafil, warfarin, furosemide, spironolactone. However, as we can notice, this patient has some sort of persistent pulmonary hypertension, so posentan was then added. At 3 months follow-up, her 6-minute walk test was 440 meters, which was good compared to his previous presentation. So in summary, chronic thromboembolic pulmonary hypertension is a potentially curable disease. Diagnosis needs a high index of suspicion. Absence of a known history of venous thromboembolism does not exclude CTEPH. VQ scan is the recommended screening test. However, as we said, CT is now a very good modality if was performed in a good with a good machine and a good operator. It's better to refer to expert centers. Pulmonary endarterectomy is a gold standard for CTEPH. Medical treatment and pulmonary angioplasty for inoperable or persistent should be considered. Thank you.
Thank you so much, Ahmed. This was marvelous presentation, actually. I enjoyed it a lot, and I have many questions. I think also Zahran and Haitham have many questions to you. So to start with a comment, as you mentioned, the CTEPH is a curable disease, and among the types of pulmonary hypertension, the several types of pulmonary hypertension, if we appropriately treat this type of pulmonary hypertension, we can achieve a complete cure. This is a very important point. I'd like to ask you about the VQ scan and CT pulmonary angiography. Why the VQ scan is the gold standard, and what is the advantage of VQ scan over the CT pulmonary angiography regarding the detection, regarding the diagnostic consideration?
VQ scan is the oldest modality for diagnosing of perfusion mismatch. The first point. Second point is that VQ scan is better for diagnosis of peripheral disease. But this data that showed that VQ scan is a gold standard method of screening is very old data, during which the CT was still is not as good as today. With the new machines and new and the very good expert that are now available, CT can diagnose most of cases of suspected chronic thromboembolic pulmonary hypertension, even if the patient had only peripheral disease. And some centers in Europe already use CT pulmonary angiography, but actually these centers are dedicated pulmonary hypertension centers with a dedicated radiographer that are experts in pulmonary hypertension. They use CT pulmonary angiography as a screening method. However, I think VQ scan is still a very cheap and a very sensitive method to use, particularly in our country. So I think till now I use VQ scan as a screening method before proceeding in the diagnostic algorithm.
Thank you, Ahmed. As you mentioned, the VQ scan is still the gold standard till the wide availability of the highly dedicated CT machine. I'd like to simplify it like the coronary artery disease. We have the microvascular angina and we have the epicardial coronary artery disease. So to detect the microvascular angina, we need the functional imaging with maybe thallium or vitamin echo to detect with stress, maybe the functional ischemia. However, the CT pulmonary or the imaging modality detect mainly the epicardial and or the macrovascular abnormality rather than the microvascular abnormality. So regarding surgery, there is a lot to say regarding surgery. It's a challenging procedure with a high risk mortality, as you mentioned. So, what do you like to add regarding the preoperative preoperative preparation, operative and post-operative preparation, and the use of the mechanical circulatory support in this type of patient?
Okay, in fact, the mortality of pulmonary thromboendarterectomy is not that high. It's less than 4%, and in some center it's between 1 to 2%. So it's not that high. But, for those group of patients that have a very poor survival if left untreated. The problem is when you find patients with CTEPH that are misdiagnosed as idiopathic for several years and then diagnosed. So patient with long-standing disease with very high pulmonary vascular resistance is usually have peripheral disease in the non-occluded segment, which is similar to the idiopathic type. This dramatically increases the mortality of the surgery. But if we diagnose those patients very early, mortality is low and survival is extremely good. طبعا في نقطة another important point that ICU care يعني intensive care post-operative intensive care management in those patients need an expert intensivist. Those patients are exposed to total circulatory arrest and hypothermia during surgery, and they are usually exposed to reperfusion lung injury after surgery, and management of mechanical ventilation is usually challenging. And also the neurological changes after total circulatory arrest is sometimes challenging. Post-operative care is one of the most important determining factor for mortality in those patients. So أعتقد if we had a very expert center and patients that presented early and good intensive care, the mortality is good.
So again, is it a must to use the mechanical circulatory support like a VA ECMO during the post-operative period in these type of patients?
No, not mandatory. Yani in some patients that have a very resistant right-sided heart failure, so we sometimes use ECMO. Most of the patients do not need ECMO post-operative.
Okay. Another important point is the new technique, which is the balloon dilatation for the CTEPH. Now it is recommended more for the peripheral sites or peripheral chronic thromboembolic pulmonary hypertension. And I think several centers have increasing experience in doing this type of patient. So can we repeat? I know that you mentioned some of the precaution during your presentation. Can we repeat this precaution regarding management of the patient with balloon dilatation? How many sessions? How would we assess our result and the complications that can we encounter with this type of intervention?
Okay, thank you, Karim. For those patients that need pulmonary angioplasty, they are usually has, as you mentioned, peripheral disease or persistent disease after surgery. We should first select a patient that are really in need of this procedure that, as you mentioned, need many sessions. Second thing is a patient who had an extensive peripheral disease usually have a worse result than the patient who's localized peripheral disease. The third point is doing this procedure should be done in several sessions, up to 5 or 6 sessions, between 2 to 6 in most of the studies. Why? Because we have to avoid reperfusion injury. So we use a very gradual dilatation. We use a small balloons. We dilate at low pressure and then increase gradually the pressure. We monitor for any reperfusion injury, any perforation, hemoptysis, And then usually we start with the lower lobar branches, because the lower lobar branches are the most vascularized part of the lung, and also we expect more hemodynamic improvement and more hemodynamic consequences after we open this lower lobar branches. In many centers, they start with the right lung, and particularly the lower right lobar part. Usually يعني most of the center you start with a very small balloon like 1.2 to 2 millimeter balloon, and then increase gradually. The most the most feared complications here is reperfusion injury. Many patients need mechanical ventilation, and and this was one of the predictors of mortality. If the patient needed mechanical ventilation due to reperfusion pulmonary edema after the procedure, this is a very high predictor for mortality. Sometimes you might find the patient had hemoptysis due to actually we do dissection, sometimes perforations. So the procedure is not without risk. However, experience is increasing all over the world, particularly for like cardiologists that are already doing a lot of angioplasty and coronaries and different vascular tree. So I think the training curve will be extremely rapid for any interventional cardiologist if we start. I think also we need a very good intensive care in the to address any major complications that might occur after this procedure.
Thank you, Ahmed. This is very good, the message regarding the collaboration of different specialties in the management of pulmonary hypertension. It's not a cardiologist only on board. It's cardiology, intensive care, anesthesia, maybe cardiothoracic surgeons. So it's a collaborative work rather than a one man show. So Zahran, do you have any other question? And Haytham?
So thank you, Ahmed. Thank you, Zahran. Thank you, Ahmed, for this elegant presentation as usual. I have two questions. The first one is about the endothelin receptor antagonist or endothelin receptor blockers in these patients. Do they really do any significant benefit for these patients after the endarterectomy, or the benefit is minimal, especially for the high residual pulmonary resistant patients? And if the bosentan is the drug of choice, or we can use the newly direct ambrisentan based on your experience. And the second question will be the assessment of recurrence in patients with the balloon pulmonary angioplasty. If there is an incidence of high recurrence or high recoil in these patients or not.
Okay. For the first question, بالنسبة للendothelin receptor antagonist, the guidelines already mentioned that we can use the specific therapy for pulmonary hypertension for those group of patients if they have a persistent pulmonary hypertension or inoperable pulmonary hypertension. However, the data are more for riociguat, which is a guanylate cyclase stimulator. Also, we had data for macitentan, which is one of the endothelin receptor blockers. However, no mortality benefit at all from all the mentioned drugs, and no head-to-head comparison between those drugs and pulmonary balloon angioplasty. In most of cases, we combine surgery, then maybe pulmonary angioplasty. Then, if the patient still has some persistent pulmonary hypertension, we can keep specific therapy. For the recurrence correlated the extent of the previous disease. If the patient has extensive peripheral disease and they need many sessions, we anticipate higher rate of recurrence. The main problem of pulmonary angioplasty is not recurrence. The main problem is the acute complications during the procedure and in the first 24 hours of the procedure. Is not the recurrence is not the big problem here. In selected patients, the recurrence rate is very low. Particularly in those patients who had a localized peripheral disease that you can localize the branch and dilate and reperfuse the occluded area. Those patients usually have no problem at all. Because we already dilate fibrotic tissue. So you can see the recoil on table. We anticipate some sort of recoil in the first few days, and you can monitor this with the hemodynamic, like echo, maybe right heart cath and follow up. But the recoil is not usually that is not making a big problem in most of the series that I up to my knowledge.
Thank you so much, Dia. Zahran, do we have any other comments or questions?
Thanks a lot, Dr. Ahmed Hassan, for this wonderful wrap up for this very important and actually challenging issue of chronic thromboembolic pulmonary hypertension. Dr. Ahmed Hassan gave us a brief about the condition, about the diagnosis, and about the different therapeutic options involving interventions, involving surgeries, and involving medications, including the newest medications available for this situation. Thank you so much, Dr. Ahmed, for joining us tonight. We really learned a lot from your great experience in this particular field. Thank you, Dr. Karim Mahmoud, for offering us the very targeted overview for the different conditions of venous thromboembolism, the one with hemodynamic instability and the one with without hemodynamic instability, and the pregnant ladies and the post-cancer patients, and for how long should we give the anticoagulation according to the risk stratification of every particular patient. Thanks a lot for all our CBC viewers who joined us tonight and interacted actively with us. Next week, I think we'll be having and scheduling a very nice session about the pericardial diseases, which will be also arranged by Dr. Karim Mahmoud and Dr. Aziz Suleiman, and you will find it to be very interesting, inshallah. And we have a couple of more surprises in the next couple of months. So stay tuned and follow our page and follow our channel on YouTube. Thank you so much, and see you next week.